rapid access to comprehensive oncology data and survival analysis. This is the Oncotoolkit.
Let's be honest, for busy clinicians, assessing liver function in HCC patients is a huge time sink, and it's full of risk. We're talking about turning hours of painful guideline checks into minutes, instant, streamlined, and completely evidence-based. You know the drill, right? You're trying to assess a single patient with HCC, and suddenly your screen is a mess. You've got half a dozen different browser tabs open. You're trying to juggle all these essential but totally separate scoring systems. It's not just inefficient, it's a recipe for transcription errors. I mean, look at this. You're bouncing from the Child-Pugh score over to the ALBI grade. Then you have to calculate the MELD-NA, figure out the BCLC and HKLC staging, and finally, check the Milan criteria. Each one is absolutely crucial, but trying to wrangle them all together creates this incredibly complex, time-draining manual workflow. Okay, so let's get into the why. Why is this assessment so critical? Well, it's all about moving past these old subjective measures to get a truly clear, objective picture of a patient's liver function. And here's the bottom line. We have to objectively quantify liver reserve. It drives every single major treatment decision we make. It's how we figure out which patients can safely handle a major hepatectomy versus those who are at a really high risk for post-hepatectomy liver failure. It tells us who can tolerate therapies like SBRT without severe toxicity, or, who's likely to get the best outcomes on systemic agents like lenvatinib. It's everything. For decades, the one we all learned was the Child-Pugh score. It was proposed way back in 1973 by Pugh and his colleagues. Its whole job was to measure cirrhosis severity, and it's the source of those Class A, B, and C stratifications we all know: well-compensated, functional impairment, and decompensated disease. But this slide right here, this gets to the fundamental problem with Child-Pugh. It depends so heavily on subjective inputs, like trying to grade the degree of ascites or encephalopathy. You could have two excellent clinicians assess the exact same patient and come away with two different scores. And that lack of reproducibility, that can lead to major triage errors. That's why we have to lean on objective, consistent lab markers instead. So let's talk about the modern, evidence-based arsenal. These are the tools that let us integrate objective data to build that complete and, more importantly, reliable clinical picture. And this brings us to the ALBI grade, which was a real game changer when Johnson and his team developed it in 2015. Its power lies in its beautiful simplicity and objectivity. It only uses two things: serum albumin and bilirubin, two completely standard, reproducible lab values to assess liver function and powerfully predict survival in our HCC patients. And just look at this table. This shows you how clinically useful it is. The ALB score sorts patients into three really distinct prognostic groups. If you've got a score of -2.60 or less, that's grade 1, good prognosis. Between -2.60 and -1.39, that's grade 2, intermediate. And anything greater than -1.39 is grade 3, which signals a poor prognosis. These are actionable, data-driven grades you can actually use. And look, this isn't just a nice idea. It is backed by some serious evidence. What you're seeing here is the ROC curve from the original validation study. It shows the ALBI score's incredibly high predictive power for patient outcomes. See how that curve bends sharply up and to the left? That's the statistical signature of a test that's excellent at telling the difference between patients with good and poor outcomes. This is the kind of solid science we need to be basing our clinical decisions on. But of course, ALBI isn't the whole story. A truly complete assessment needs more. We still rely on the MELD-NA score to predict 3-month mortality and prioritize transplant candidates. We use the latest 2022 BCLC staging from very early to terminal as our Western standard for treatment guidance. Then there's the HKLC staging, which is an alternative that often points toward more aggressive treatment. And of course, the Milan criteria are still the gold standard for figuring out transplant eligibility based on tumor burden. So, how do we take all this amazing science and actually apply it instantly and accurately right at the point of care? Let's take a look at how this all comes together in a streamlined, automated workflow inside Oncotoolkit. Okay, inside Oncotoolkit, the process could not be simpler. Right here in the ALBI score tool, you just entered two numbers into these fields: total bilirubin and albumin. That is it. No subjective guesswork, no complicated data entry. And what you get back isn't just some random number. You get a completely transparent result. We like to call this our anti-Blackbox workflow because you can see every single step of the process. The second you hit calculate, boom, the result is there. So in this example, the tool instantly gives you a score of -2.12, which it correctly identifies as an ALBI Grade 2, clearly flagging intermediate liver function. It's instant, it's evidence-based, and it's something you can act on right away.
And this really gets to a core principle for us. We don't believe in black boxes. The math and the reference tables are right here for your review.
So if you look at this expanded view, this calculation logic section breaks the whole thing down. It shows you the exact formula from that original Johnson paper, it shows the values that you entered, and it shows precisely how they combine to produce the total score. This kind of transparency is what builds clinical trust and lets you verify everything. But the power of a tool like this goes way beyond just the individual patient encounter. It's actually designed to seamlessly bridge that clinical assessment with your academic research. So you can save the results for your patients, and then, with just a single click, export your entire cohort into a clean, totally research-ready CSV file. Now, this isn't meant for your EMR. This is the first step toward your next discovery. It's all about turning your clinical work into research data, absolutely effortlessly. The research workflow is literally just 2 simple steps. First, you prep your data using the integrated CSV polisher. It helps handle any missing values and gets your variables formatted correctly. Second, you upload that polished file directly into the survival analysis tool. This slide shows you the entire research ecosystem at a glance. On the left, you've got the CSV polisher getting your clinical data ready to go. Then, on the right, you just upload that clean data into the survival analysis tool to automatically generate Kaplan-Meier curves. You know, those stepwise graphs that show survival probability over time, and calculate your hazard ratios. You're going from bedside assessment to a publication-ready analysis, all in one unified environment. So, to wrap it all up, the workflow is instant, it's streamlined, and it's built on a solid foundation of evidence. This is really how you transform your HCC assessment workflow, freeing up your time while seriously boosting accuracy. And that brings me to a final thought for you. When you have the ability to capture clean clinical data this easily and move it directly into powerful analysis tools, the real question becomes, how could this streamlined workflow accelerate your next research project?